कानू, अभी आगे ऊपर है क्या? आपको भूख बहुत तेजी से लगी है क्या? अरे आपको भूख बहुत लगी है क्या? कब नहीं खाया? हाँ तो अभी थोड़ा देर रुकिए ना, आ रहा हूँ। हाँ ठीक है, वो डैडी को कुछ दे दो, क्या खाना। हाँ हाँ हाँ।
लाइट बिल कितना है, कितना का? लाइट बिल आपने बोले था कि सर ने सही दिया। देखो सुबह बजट
हाँ,
तो कह रहे हैं नहीं
सर,
यार।
1 जुलाई मरी जैसे तुमने पैसा। हाँ,
देना हो देना, नहीं
1 जुलाई, 1 जुलाई। हाँ, 1 जुलाई। कोई बात नहीं। हाँ। सिक्सटी फोर, 62, हाँ तो 62।
Make Dr. Hudedar co-host. Good evening, Gite sir.
Sir, good evening, sir.
So nice to see you again. Huh?
Yes.
So
So,
congratulations. People, they don't know that now you're a dean in Nasik.
sir, it's additional administrative responsibility, sir. Nothing more than that.
No, but it's a very good designation also. No?
Yes, sir. Yes, sir.
Pankaj has not joined. I telephoned him, but he did not pick up.
Pankaj is in AUS.
USA?
Ah.
Oh, you are in USA? Oh, okay. Sorry. हाँ? Okay. नहीं वही है तो अपना आज से फर्स्ट क्लिनिक चालू हुआ ना. ओके. मैं मैं बोला आपके बिना चालू होना मतलब इट्स नॉट अ गुड थिंग. इसके लिए मैं बोला नो प्रॉब्लम. हाँ अभी शुरू करते हैं. योर टाइम यू कैन ज्वाइन इन बिटवीन. ओके थैंक यू. पंकज का ही फोन था. ही इज इन ईयू है ना.
Yes, sir. Yes, sir.
हमारा
हिरेन
बंदा
है,
हाँ
हिरेन है, आप है, मैं हूँ, तो चलता है कोई इशू.
हाँ ना नो प्रॉब्लम. ये तो क्या फर्स्ट लेक्चर अपना फर्स्ट क्लिनिक है. एंड ही इज ऑलवेज बीन अ पार्ट ऑफ इंटीग्रल
Yes.
पार्ट ऑफ आवर्स. सो बस हमारा रेसिडेंट ज्वाइन करके चालू करे तो हम लोग चालू कर देते हैं.
हाँ, करने में कोई हर्ज नहीं. ऐसे ही आज इनिशियली ऐसा भी सिंप्लीफाइड टॉपिक चूज किया हम.
Correct. And it is we have selected like 3 cases, ureteric complicated obstructed cases. So like how to manage it and how to answer in exam, that is the most important thing.
Exactly.
Because I have seen that similar cases will come in exams. And if it is simplified and they can answer well.
Sir, it is a very common problem and commonly asked things in exam. Whenever in the in X-ray, CT scan, short case, या वार्ड राउंड, ऐसा कहीं ना कहीं तो ये आ ही जाता है.
Correct. Who is answering today?
Hello. Yes, sir, I will answer.
Kaun?
Paras, sir.
Paras, you are answering. Who else is answering?
Sir, Rahul. Good evening, sir.
Okay, Rahul. Rahul, you are answering. So 2 of you are answering or one more person? Okay, Paras and Rahul.
Yes, sir.
Okay, Rahul, you are from?
Sir, I am from Institute of Urology, Dhule.
Oh, good, great.
आज नहीं आ रहा.
Paras, why is not starting, is not able to join?
ठीक है.
Bridges is not able to join?
Hello.
Hello?
1 minute, sir. 1 minute.
Okay. Make a full screen.
Yes. So start.
Okay, so today two people are answering. One is a Paras and second is Rohan, na?
Rahul, sir.
Rahul. Okay, fine.
Okay, we will start, sir.
Yeah, we start.
Yes. A 30-year female presented with a complaint of pain over right flank since 3 months, burning micturition, increased frequency since 3 months, and pain over left flank region since 1 month, and hematuria in 1 month.
Okay. So, Paras, what are the important questions you want to ask?
So first of all, we will ask about the characteristic of pain, the site, onset, character, aggravating relieving factors, any associated factor like nausea, vomiting, or severity of pain. We will also like to ask about hematuria.
One
Was it
minute.
painful
Paras,
or painless?
I think you and Brijesh are in the same room. That is why there is a echo. You will have to, two gadgets cannot be in the same room. Okay, anyway, go ahead.
So we will like to ask about hematuria also. Uh, Regarding hematuria, we will ask about it is painless or painful. What it is associated with passage of clot. What is the shape of the clot? Is it there any other associated symptoms like dysuria, lower urinary tract symptom, fever? Was it associated? Is there any history of any urethral instrumentation? Is there history of any radiation? Is there any history of chemotherapy? Is there any history of antiplatelet or anticoagulant drugs? We will also like to ask about burning maturation. It is increasing or not, or it is associated with any suprapubic pain or not. Yes, sir.
So, Rahul, do you want to add anything?
Sir, pain, onset, duration, and progression of the pain. Whether pain is colicky or pain is dull aching in nature, or intensity of pain, which whether it is mild, moderate, or severe in nature. Whether pain is associated with any nausea, vomiting. Pain is associated with any position or aggravating factor or relieving factor of the pain, or in pain is associated with any other lower urinary tract symptoms like urgency, frequency, urge incontinence, as well as associated with any dysuria, and any history of lithuria in a recent past associated with hematuria or not. And I would like to see the whether hematuria which is painless, complete, or total, or initial or terminal hematuria associated with any clot or any tissue beads in the blood, as well as it is associated with any lower urinary tract symptom, fever, any history of trauma, any history of endoscopic surgery in recent past, sir. So I would like to know all these about the pain and associated symptoms.
Okay, Brijesh, go ahead.
Yes, sir. Patient was relatively asymptomatic before 3 months when she developed pain over right flank region. Pain was colic in nature, sudden in onset, radiating from loin to groin. gradually
Your
progressing and
slides
has
have not
increased.
changed. You have not changed the slide. Okay, go ahead.
The patient was relatively asymptomatic before 3 months when she developed pain over right flank region. Pain was colic in nature, sudden in onset, radiating from loin to groin, gradually progressing and has increased since last 1 month, associated with nausea and vomiting. No specific aggravating factors, relied on taking analgesics. Patient also had complaint of left flank pain, which was similar in nature and relied on taking analgesics.
So Rahul,
Yes, sir.
whenever such patient came to the casualty, young female, bilateral loin pain, right for 3 months and left for 1 month, colicky, radiating, associated hematuria. So what are the things come in your mind? This is the only just patient is sitting in front of you.
Sir, points in the history suggestive of sir stone disease, which is most probably in ureteric in origin, bilaterally. Also, colicky pain can be associated with the blood clot, which is obstructing in the ureter. After that, sir, any cystic disease which is present, which can lead to the bleeding, and that lead to the colicky nature of the pain, as well as the infection, which lead infective etiology, which can lead to the similar kind of the pain. And sir, as she is female, 30-year old, I would like to do the UPT of this patient also, keeping in the mind of pregnancy also, sir.
देखो, bilateral loin to groin pain, there should be some bilateral ureteric pathology.
Yes, sir.
And on the contrary, it should be in the lower ureteric pathology.
Yes, sir.
Okay, so
Yes.
what are the things bilaterally? So bilateral stone disease, age and associated hematuria, associated nausea, vomiting, type of pain, that can be dependent. So first things come in anybody's mind is
Stone disease.
urolithiasis or stone disease.
Yes.
Another things what you have told, if examiner asks, please defend your second, third, and fourth diagnosis. So
Yes.
for that, what are the positive findings? If you are telling about the cystic disease, so bilateral cystic disease may be seen at the age of 30 years, but why there is a bilateral bleeding, why there is a bilateral infection in that cyst, and if the cyst is there, the pain is only in the loin to groin towards the umbilical region.
Umbilical.
Okay,
Yes,
and
sir.
that is usually a dull aching pain, dull pain, because that is happened due to the stretching of the capsule or stretching of the cyst or
Yes.
infection of the cyst. So that pain is not matching with the pain what presented in this case. So the cystic disease is excluded. Bilateral PUJ is also excluded. So if it is either a ureteric, lower ureteric, there may be a congenital strictures, acquired strictures, instrumentation, history, some LSCS, bilateral in recent past, partial strictures. These are the things to be excluded in incoming negative histories.
Yes, sir.
So primarily, I will think at this juncture prominently towards the urolithiasis. This should be the answer in the exam.
Yes, sir.
And you have to defend your answer. 1, 2, 3, 4, 5. Clinically, groin to groin pain, colicky pain, associated hematuria, then age of the patient, which is commonly a ural stone disease at that age is common. That's why I am suspecting urolithiasis.
Yes, sir.
So Paras, go ahead.
Okay. Sir, go ahead.
Please go ahead.
Hematuria was since 1 month, intermittent, complete, and not associated with passage of clots.
So what
No
it
history of
suggests?
lithorid.
What it suggests? There is a 1 month hematuria. So if it is persistent throughout a complete hematuria in each and every passage of the urine, or it is in morning, only in the evening, only in the terminal phase, or only in the start of at the start of the urination, it is associated with the clots. It is not associated with the clots. If it is associated, then what are the what is the shape of the clots? Then is it associated with some tissue bit, as we already told? So all these things to be asked in relation to the hematuria. So persistent 1 month hematuria is 1 month intermittent, you told. Intermittent, complete, and not associated with passage of clots. So where is that hematuria may be coming from?
Sir, as patient is not passing any clots and hematuria is intermittent and complete hematuria, may be possible from sir, clot coming from ureter or clot coming from the bladder.
Why there are no clots? That's what he has given in his.
Then, sir, due to the movement of the stone, it may abrade the mucosa of the ureter that lead to the hematuria, and that causes intermittent hematuria. And sir, as a history of the patient, she is not passing any clots. So, sir, exact location cannot be commented.
So the first question you should ask, is it painful hematuria or it is painless hematuria?
Painless. Yes.
Then another question you ask is, it is associated
Number
with
of
clots or it is not associated with clots?
number of episodes in the day.
Number of episodes. Yes,
Episodes.
exactly.
Now, at present, patient is having hematuria or not. Whether this hematuria is associated with fever or any history of trauma to the patient, any endoscopic procedure done in the recent past, or rarely at the age of 30, she is on antiplatelet or on any antiplatelet, we should ask about.
Exactly. So both बताओ आगे पढ़ो.
Then, sir, I would like to ask for negative history. Is she is passing any? She is having any lithuria? Any history of any sir bilateral lower leg swelling, puffiness of the face? Then any history of jaundice, headache, backache, or sir any other endoscopic surgery history?
Why you want to ask jaundice, headache, backache?
Sir, pain is in the right flank pain, may be associated with gallstone disease. So I would like to exclude that. That's why I would like to ask about jaundice, headache.
In which urological disease patient is having hematuria and headache?
See, don't put your lag in the problematic area. You understand?
Yes.
Because what will happen if you divert, then unnecessarily, like Dr. Gite has asked you, they will ask you such questions that you will have no answer to that.
Yes.
Sir is right. If you remain simple and to the point, exam is not very tough. If you try to talk something extraordinary, then this will happen. You will get deviated. You have to lead the examiner to investigations and treatment.
Yes. Yes.
Exactly. Then some examiner may ask you why that cholecystitis patient is in urology exam. So unnecessarily diverting the things is not good.
Yes.
So you are expecting urolithiasis, then stuck with urolithiasis. Don't let examiner to go outside that topic.
Yes.
Okay.
Anything that you say, if you justify, examiner will be happy.
Agreed.
Okay. And here we are all here to learn. We are also learning from you. You are also learning from us. So be very relaxed. We are very friendly and we want to take you to the right path, the way to present and to reach there. Okay. So all of you be very relaxed with us. Okay.
Okay.
Yes.
Yeah. So Bridges, go ahead. Manjit Singh wanted to answer. I can't find his telephone number.
Manjit Singh. दिख रहा नहीं है।
Bridges, go ahead.
Yes. In past history, patient was admitted for fever with chills and was managed with IV antibiotics at local nursing home 8 days back. History of right URS plus DJ stenting for right ureteric calculus 5 years back in view of 5 mm mid right ureteric impacted calculus. And history of cystoscopy plus right ureteric dilatation 3 years back due to right ureteric stricture and pain in right flank.
So one more diagnosis, what we are expecting or suspecting, except the stone disease, is there may be a history of instrumentation, as I told before, and there may be some stricture, acquired or congenital. So there are chances of acquired stricture. Then already there is a history of dilatation of that particular stricture. But how then the question will come: why? What is the nature of the stricture? What is the length of the stricture? Then how it is got dilated? Using what? So these are all questions to be asked in relation to that particular event and the surgery done in past.
Yeah. And I want to add, which is not here. Uh, just remember, 1.5 year back, she had undergone uh, laparoscopy for endometriosis.
So
Okay.
one more disease then.
Yeah.
Sir introduced one more pathology.
Correct. So now, Paras, what are the probable diagnoses? Now, what is coming into your mind?
A 30-year-old lady coming with bilateral flank pain, which is colicky in nature, and sudden onset and radiating also to most common diagnosis is urolithiasis.
Okay.
With
One is
a with a known case of right ureteric stricture.
Okay.
And
And now,
there is fever and chills, so there can be urinary tract infection, or due to back, if there is a ureteric stone, there can be back pressure changes leading to pyelonephritis or pyelitis.
So if it is a pyelonephritis or pyelitis and back pressure changes, there should be some fever. No?
So
There,
there is a fever for 8 days back for which he has taken antibiotics.
okay.
There
Then
is
if
past
there
history.
is
A patient admitted with fever and chills and was managed with IV antibiotics.
yeah,
okay.
fine. So, Bridges, complete your history and then we'll go ahead.
Yes, sir. We had one laparoscopic endometriosis release and adhesivolysis in 2 years back.
Correct. Any other positive history or anything?
No,
Family history?
sir. She was non-hypertensive, non-diabetic, no any history of tuberculosis, hypo or hyperthyroidism, no allergies. Family history was insignificant. She is on mixed diet, normal appetite, regular bowel, and normal bowel habits. Bladder altered with increased frequency and burning micturition. Sleep cycle normal. No any addiction, non-alcoholic and non-smoker.
Fine. So Paras, now what else? What you want to do?
So we will examine the patient. We will do general examination. We will look for palate, thrust, clubbing, cyanosis, lymphadenopathy. We will see for the vital signs, pulse rate, beat, blood pressure, temperature. We will do a head to toe spine examination. We will do a systemic examination focusing on abdomen. We will see for any flank fullness uh, or renal angle fullness. We will look for renal angle tenderness or any tenderness in flank region. We will examine the external genitalia of the patient also.
Okay.
So, what are the things you are expecting on general examination and abdominal examination in this patient?
So, in general examination, if patient is in acute pain, there can be tachycardia. If there is fever, also there can be with temperature rise, tachycardia. Uh, Depending upon the severity of hematuria, there can be pallor. Uh, in systemic examination, we will look for renal angle fullness, fullness in flank, renal angle tenderness. Is there any kidney which is palpable or ballotable? We can feel for any bladder lump, suprapubic tenderness.
So, why there will be the chances of bladder fullness or suprapubic lump in this patient?
So patient is having a history of burning micturition, which can which may with fever. Patient can have UTI. Patient may have difficulty in some post-void residual volume leading to cystitis.
Why she should have difficulty in passing urine or more post-void residue?
Sir, because of patient had multiple endoscopic surgery, it may be
Exactly.
possible she may have submeatal stenosis that lead to the bladder increased frequency burning micturition due to incomplete bladder emptying.
Submeatal stenosis is wrong word in female.
Urethral stenosis.
Urethral, sir.
Female patient है ना?
Yes, sir.
I think.
हाँ. So it is a meatal stenosis.
Meatal stenosis.
My question is, good morning. I'm saying good morning because I'm in US at this time. So my question is, does stricture cause post-void residue?
Sir, incomplete emptying that can be counted as a post-void residue in this patient.
So
Nice, sir.
you see, if we stretch it, it is possible, but more often you see post-void residue will be very, very unusual with strictures because the detrusor is normal. So patient will have a prolonged slow void, but to have post-void residue is very, very unlikely. Yes, if the patient is old, associated diabetes, any other reason for reduced detrusor contractility, then it is okay. And again, in general examination, don't start with ifs. Okay, if he has acute pyelonephritis, then there will be tachycardia. You know what your patient has. Okay. So the most important thing in general examination I would be interested in is, you see, how you should be answering in questions. What is your present differential diagnosis and what can it cause in general examination because of your suspected differential diagnosis? So your differential diagnosis first is probably a stone which is causing upper tract obstruction. So the most important thing I would look for is blood pressure. Okay. Means it is, as in the last slide it was mentioned, that looking for say pallor, edema, it is possible, but or say for that matter say icterus, it is possible, but it will be very, very unusual. So blood pressure will be the most important thing. And then you say what are the possible complications of these diseases and look for them in your examination. So don't, you see, understand that we are not giving an exam of final BBS. So don't cover everything. You are already a consultant now and you will be a super specialist soon. So look for first your system, and then every answer should have a system in it. What is my differential diagnosis, उसमें commonly क्या होता है, उसके complications क्या है, और फिर unusual चीज क्या है. So go in that sequence.
Yes.
Agreed. So I will elaborate slightly about that stricture point, sir. Sir, stricture, if the detrusor is normally functioning, in spite of luminal narrowing, detrusor try to overcome that resistance provided by luminal narrowing, and the majority times the passed urine is adequate. The post-white residue is
Yes.
slightly less. But when that stricture is reaching towards majority part is occluded. For example, it is occluding stricture, or completely it is involving the whole of the lumen is compressed, or involving the disease. In that situation, there is a back pressure changes, there is a post-white residue, but early phase, definitely that is the point where we can differentiate between the stricture and the BIP in male.
Absolutely. Well said, sir. Please proceed.
Just go ahead.
In general examination, patient is conscious, cooperative, well oriented to time, place, and person. Weight of the patient is 60 kgs. Height is 162 centimeter. Pulse is 86 beats per minute. Carnopsis score is 100. Blood pressure is 122/80. Respiratory rate is 18. Currently, patient is febrile. SpO2 is 98% or level. No any evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Head to toe and spine grossly known. Next. Patient was examined in a well-lit room with proper consent in supine position. Abdomen is flat, centrally placed umbilicus, normal thoracoabdominal respiration, no scars, sinus, or dilated veins, no visible swelling. Right renal angle fullness visible, no visible peristalsis or pulsation. Hernial sites are clear. On palpation, temperature was normal. No obvious lump present. Right renal angle tenderness present. Below table right kidney present. Hernial orifice, no cuff on impulse. Spine, no deformity or tenderness. Abdomen, tympanic node heard, and renal angle dullness present. No any bruit. Bowel sounds normal.
So what does palatable kidney mean?
Sir, any pedicled structure like kidney, which is having a renal artery, which is hanging from the aorta. So, kidney is mobile between the anterior and posterior axis, as well as superior inferior axis. Whenever kidney is palatable, means it is palpable between the two examining hand, anteriorly and posteriorly.
So would a normal size kidney be palatable?
No, sir. Normal size kidney is not palatable. If it is enlarged, like in hydronephrotic kidney or any mass, it is possible to be kidney to be a palatable kidney.
Okay. Now, do you expect in this patient to have a palatable kidney?
No, sir. Because, sir, uh, 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 though it has on the right side, she is having prolonged recurrent stricture, which may lead to the hydronephrotic kidney. But because of chronic nature of the stricture, kidney will not be so much hydronephrotic, so it cannot be palatable.
But she has a stone also, maybe.
Rahul, two,
Yes,
three
sir.
important points. In a child and thin patient, kidney, in normal kidney also sometimes palpable. That is one. All bimanually palpable kidneys are palatable or not
Ba-
palatable?
Palatable, sir.
Two sentence. No. All palatable kidneys are bimanually palpable, and all bilaterally palpable kidneys may not be palatable. So the difference is that if kidney palpable है इसका मतलब palatable है ऐसा जरूरी नहीं है, लेकिन palatable है मतलब palpable है.
Yes.
Exactly. अभी आपने दूसरा जो पॉइंट रेज किया है कि patient had a back pressure changes, then perinephric some collection, then fixation of the kidney and mobility is restricted. That is one angle or one hypothesis of not palatability. But if it is only hydronephrotic kidney due to lower ureteric obstruction, then that kidney may be bimanually palpable as well as palatable. Until and otherwise it is got infected and the perinephric fat standing makes the kidney fixed, then only the palatability will go. Otherwise, normal kidney, whenever it is hydronephrotic, it is bimanually palpable, it is palatable, and it is moving with respiration. Any structure who has a direct or indirect contact with the diaphragm is moving with that structure moves with respiration. So these are basic MBBS fundas. Sir, Pankaj sir.
So what my thinking was that you see, I missed the first slide. What is the duration of this disease?
3 months on right side. And
Okay.
already in the past, she underwent surgery on right side of dilatation or stricture.
Oh, okay. So basically, my thinking here was that in a patient with short duration history, usually the kidney will not be so enlarged to be palatable or palpable. So it is very, very unusual for a ureteric stone to cause hydronephrosis enough for the kidney to be palatable. The moment you say a palatable kidney, my mind starts thinking about whether there is any associated anomaly like pH junction obstruction, which will cause so much enlargement that kidney is palpable. But yes, rest of the things I agree with what you have said.
Yeah. So, but in this case, now the stricture is since last more than 3 to 4 years. And she has got,
Yes, so a long duration disease or some associated chronic obstruction, only that can cause a hydronephrotic palatable kidney. And as sir has very rightly said, if it's a very, very thin patient or in some small children, yes, even normally placed kidneys are normal sized kidneys are palatable.
correct. Fine. So here it is that means you have to you can justify it because it is a long-standing obstructed system. It may be palatable or palpable. Okay. Now next, what do you want to do?
Sir, I would like to do routine investigations in the form of CBC, renal function test, urine routine microscopy, and sir, along with that, I would like to do ultrasonography of kidney ureter bladder and X-ray KUB.
You see, again, I have got two comments here. Drop this word routine, Rahul. Okay, there is nothing routine in urology.
Yes.
Okay.
Yes.
Any investigation you do, there should be some reason for it. So stop saying routine investigations.
Yes.
Okay, okay, please proceed.
No. So if you are doing this investigation as a basic laboratory and radiological investigations, what you require is complete blood count, and what you expect in that is there may be a leukocytosis, there may be a neutrophilia. What you expect in the urine routine, there may be a pus cells, there may be epithelial cells, there may be some RBCs. So there may be some protein loss if it is a chronic disease. So these are the things you may expect in urine routine. And what you expect in sonography? So you have to start from kidney. So size of the kidney.
Sir,
Then
I would like to see the size of the kidney. Then,
okay,
sir, any gross hydronephrosis, any stone with, sir, I would like to see the parenchymal thickness.
don't go hepatitis. If you are talking about kidney, talk about it.
Sir,
So if it size
in
of the
the
kidney,
kidney, sir, size
particle
of the kidney,
thickness,
cortical thickness, corticomedullary differentiation. Then,
exactly.
sir, I would look for any hydronephrosis in the pelvis as well as a perinephric area to look for any.
Hydronephrosis in the pelvis नहीं रहता. Hydropelvis. So listen. Size of the kidney, cortical thickness, corticomedullary differentiation, any internal echoes inside, amount of hydronephrosis, associated hydropelvis or hydroureter, then any perinephric collection. Okay. Then go
Yes.
down. Any associated stone, any associated some other pathologies. Then talk about
Sir,
bladder. Then
bladder.
the bladder wall thickness,
Yes.
then pre-white, post-white.
Yes.
So ये सीक्वेंस से वन लाइन में बताने को आना चाहिए.
Yes.
So बता दो, reports बता दो.
Please just show the report.
Yes. So urine protein macro. So pus cells 15 to 20 per hyperfilm. Albumin is trace. No red blood cells. So occasional. And 1 to 2 epithelial cells.
And blood test is positive. So it is proteinuria, hematuria, and pyuria. So is this a common organism? What they found in the urine culture? Rahul.
No, sir. Pseudomonas aeruginosa is not common organism. Sir, it is. Sir, you mean to say commensal or it is a pathogen?
Pseudomonas may be present, but routinely, what are the common organism is?
E. coli.
Sir,
E. coli,
routinely E. coli
Klebsiella,
and Klebsiella, protease.
Protease. Exactly.
Gram-negative.
So these are the common organisms found on urine culture report of any urological disease patient having infection.
Yes.
Lecture chalo.
So pseudomonas maybe, can it be a contamination? Female patient?
Sir, possible. But sir, depending upon how urine has been collected,
Is
if
the colony count?
colony count greater than 10 raised to 5, sir,
So
it is significant.
So the chances of contamination is slightly less when the colony count is, until another there is a gross contamination, then it's okay. But usually, if it is contamination, count may not be up to that mark, that is 10 raised to 5. And this patient is symptomatic. So there may be a chance of having a pseudomonas infection in your system. May not be a common. So what you will do after seeing this report?
Sir, for sensitivity, I would look for. And sir, accordingly, according to the sensitivity, I would like to start the antibiotics to the patient.
Okay.
It is
What?
only
So until
yeah.
and otherwise you get a report of urine culture, you will not start antibiotics.
No, sir. Depending upon the symptoms of the patient and pulses in the
So
urine.
at the end of diagnosis, you should have tell to the examiner that this patient had a loin tenderness and this patient had a pain. I will admit the patient, start the analgesic, send the blood for basic laboratory investigations, and start the antibiotic. Or if you don't want to admit the patient, then I will start at least this and ओपीडी में फॉलो अप करने के लिए बोलूंगा. एक ना तो बोलना चाहिए क्योंकि वो फिर यूरिन कल्चर होने तक तो तुमने बोला ही नहीं.
Yeah. So this patient was admitted as earlier for 5 days, and they had given the antibiotics, and then after that the fever had subsided. Okay. So now
Okay.
next what? Paras, now what you want to do?
Sonography.
Brijesh, have you
Yes.
shown all the reports they have asked?
No, sir, I'm showing hemoglobin.
Yeah, sure. Okay, so Paras, the question is that 10 raised to 5 is you will say that there is an infection. In which condition, even if it is less than 10 raised to 5, you will still consider as an infection?
Sir, if,
Suprapubic aspiration.
Yeah, Rahul, tell me.
sir, if specimen is collected through suprapubic catheter or Nilletons catheter through per urethra, then colony count of 10 raised to 2 is also considered as a significant.
And if the patient is on antibiotics?
Then also, sir, it is considered as a significant.
In that case, 10 raised to 1, 10 raised to 2, 10 raised to 3, or 10 raised to 4?
Sir, 10 raised to 2, 10 raised to 3, and 10 raised to 4 also considered as a significant.
Okay, fine. Just go ahead, Brijesh.
Yes. Hemoglobin was 12. WBC count 8,000. Serum create was 0.9. Sodium and potassium normal. CRP was 40. HbA1c was 5.8. INR was 0.9. Sonography.
Yeah, show the sonography. Yes, Rahul, can you read it?
Yes, sir.
I know it is very difficult to see it properly, but whatever positive findings are there, just tell us and we'll show you the report.
Yes, sir.
We will give report today, but you must able to read the sonography.
Sir,
There are n number of exam centers where they will not give the reports of sonography as well as CT also.
Sir, in upper middle plate, it is transverse section of the bladder, which is bladder wall thickness looks normal, and there is no any uh, any sh- re- sir, sir, bladder appears normal, and surround the down there is I am able to see the lower plate, which is sir, transverse section of the right kidney, which is hydronephrotic, and corticomedullary differentiation appears normal, and sir, no internal echoes has been seen in the kidney, and sir, perinephric area looks normal.
Okay. Brijesh, show the report. Just read the conclusion.
Yeah. Right kidney appears enlarged in size and shape. Cortical thinning noted. Evidence of 8.8 mm size calculus seen as lower bone. Right kidney shows moderate to gross hydronephrotic changes in hydroureter due to mid stricture containing 9 mm echo-reflective calculus in the mid-ureter. Left kidney normal in size, shape with normal homogeneous echo texture. No sign of any focal lesions. Evidence of 8 mm calculus at mid-bone. Left kidney appears hydronephrotic with upper hydroureter. Urinary bladder is well distended and appears normal. Pre-void is 407 cc and post-void is 112 cc. Bilateral renal calculus. Right mid-ureteric stricture with calculus. Hydronephrotic changes in the left kidney as described above. Changes of cystitis. Insignificant post-void residue.
Fine. So, Paras, these are the findings. Now, what you want to do?
I would like to have a CT urography of the patient.
Okay. Anything else? Why there is a post-void residual 112 cc?
As discussed, patient has having history of previous urethral instrumentation. It can be due to meatal stenosis.
Fine. So, you want to do some other investigation also, or
To rule out any stenosis, you can go for uroflowmetry.
okay, Brijesh, show them.
Yes.
I have one small question. How do you diagnose stricture on sonography?
नाही नाही सर ते चुकून लिहिलं गेलं असेल बहुत that can be म्हणजे असं की हायड्रोयुरोट्रोनेफ्रोसिस सेकंडरी टू द स्टोन आणि त्यांनी ते जजमेंट घेतलं की स्टोन हे स्टिक्चरच्या वर असावं कदाचित असं सोनोग्राफी वाले कधी कधी
But
एक्स्ट्रा
it
दोन
is a
गोष्टी
very unusual diagnosis for sonography. Means never take stricture as a diagnosis on sonography. Sonography is, yes, it will just say that there is hydronephrosis. To give such a precise diagnosis is very unusual.
Yeah, exactly. Maximum, if they can say that the stone is not seen, so there may be a hydroureter, may be secondary to stone which is not diagnosed, or there may be a stricture. But they can't
So
say
कैसा
this is
है?
a
So
definite
stricture can be
stricture.
one of the differential diagnosis which
Exactly,
you
exactly.
think. Yes, but not a report of sonography.
Yes, yes,
Sonologists usually give urological opinion also, sir.
yes.
Sir, नाही that's what I want to tell कि overriding in the another subject is nowadays fashion. So I come across one PM report. For your surprise, that person has written there is a injury to the right side of the membranous urethra. So how that person has reached to the membranous urethra, which doesn't open, sometimes brain don't open brain also or abdomen also. He has precisely seen that membranous urethra and he has notified that injury in the PM report, and that is causing the problem now. So ये सर ये फैशन हो गया है.
So better to stick to our subject only.
Exactly.
Okay, so this is the uroflowmetry which is showing the obstructed pattern. Okay, now show the CT scan. Let's go ahead. Brijesh. Brijesh, just show them all the films.
Yes.
The question is there any role of DTPA scan? First you see all the films and then tell me whether you want to do DTPA renal scan or not. Okay. The question is why X-ray KUB was not done. Brijesh, we have done the X-ray KUB, na?
Yes, sir, but it was with the patient at home.
Okay. Fine. Okay, Rahul,
Yes.
please comment fast. So we want to, it's a very long case. Lots of complications have taken place in this case, and that is why we have kept it.
Sir, this film of CT scan abdomen pelvis in sagittal section suggestive of right side gross hydronephrotic kidney with hydroureter, which is dilated up, up up to mid-ureter, and there is a radio dense shadow also seen, which is suggestive of ureter on the right side, and left side corticomedullary sir, left side kidney looks normal, sir, with good excretion as well as drainage.
And what about right side?
Sir, right side grossly hydronephrotic with cortex is thinned, and sir, upper hydroureter is seen with radiodense mid-ureteric calculus.
Okay. Paras, you want to add something?
No, sir.
So now, next what you want to do? Now, Dr. Pankaj Maheshwari asked a question. Why you want to do the X-ray KUB?
Sir,
Paras?
X-ray, sir, X-ray.
Yeah, Rahul said.
Those X-ray KUB sensitivity and specificity is low as compared to CT scan, but we have to follow up the urolithiasis patient afterwards. For that reason, we can do X-ray KUB as a investigation.
No. The question straightforward here is, you want to do X-ray KUB, yes or no?
Yes, sir.
If you want to do X-ray KUB, then why? And if you don't want to do X-ray KUB, then why?
Sir,
And also when, not only why, but when. When will you ask for X-ray?
Sir, I would like to do on OPD basis X-ray KUB to look for radio density of the stone, as well as sir, this X-ray will help me to follow up the patient.
No, so how will it help you in follow-up? Can you explain that?
Sir,
ओपीडी बेसिस पे तो सीटी भी हो सकता है ना.
2 minute job.
X-ray is having low radiation exposure, 0.7. And CT.
No, you see, again, whenever you advise any investigation, you don't advise the investigation because the problems with the investigations are low. The investigation is advised as to what are you trying to find in that investigation. So if this patient comes to me in OPD with features suggestive of obstructive uropathy, my first investigation is a sonography. Okay, sonography can be considered as an extension of your clinical examination. Once I see on sonography hydronephrosis with stones, there is no place for X-ray KUB there. You will directly go to a CT scan. Okay. So in today's time, there is nearly no role for X-ray KUB. You are adding radiation to the patient. Rather, I would say other way around. Why
Yeah,
are you
you are
giving
adding by doing
radiation to
X-ray
patient?
and then CT.
So X-ray KUB is only reserved for patients in my practice today. Say if there was a radiodense stone and before stent removal, I just want to document that patient is stone free. Even there, we have started doing a low dose CT instead of X-ray KUB. But otherwise, X-ray KUB has practically very less place today.
Yeah. So only the reason what they can reason out is if there is a small stone which is a radio opaque and they can see it on the X-ray. Then to follow up, if you are giving a medical line of treatment and you want to see whether the stone is migrating down, it is coming down or not, then and only then the X-ray is important. But if the X-ray is not showing stone and you are not going to give a medical line of treatment, then X-ray is not any use.
This is an acceptable point, sir. But again, from a practical as well as exam point of view, any investigation you advise should either say avoid the next step or change your thinking pattern. In this patient particularly, X-ray KUB is not going to change anything. Irrespective of X-ray, I will do a CT scan. CT scan will give me all the information, probably much higher than what a X-ray can give me. So at least in this patient, there is no place for X-ray KUB. This is open for debate. Means
Yeah.
I totally agree with sir. Whenever you see the sonography and if sonography shows this picture, the role of X-ray QB is over. There is no role of X-ray QB. For
Agree.
acute any ureteric colic, CT scan. Any hydronephrosis, if you are not going to do a CT scan in some situation, then X-ray QB sometimes may be helpful. If your CT is not available, you are doing practice at some rare place, that are the causes may not be acceptable in exam. But practically, sometimes in some remote places, if you are practicing, then X-ray and sonography, follow-up, whatever the Rahul is telling, some follow-up for before DJ removal, is there any residual or not? ये सब चीजें है. लेकिन every places, majority medical colleges, majority teaching institute now following either NCCT as a follow-up and contrast CT for the diagnosis. So investigation should impact your planning or change your diagnosis. Otherwise,
Agree, and I think that Paras, you should not say that radiation exposure and all that because you're just adding radiation exposure. You're not reducing it. Next step is going to be CT only.
Fine. So now the conclusion is that when such a case comes, there is not much role of the X-ray. You should ask for the CT scan, and if you ask for X-ray, you should justify why you want to do the X-ray. Okay, fine. Okay, so show the finding, Brijesh.
Yes.
See, there is a mild fullness on the left side also. I think that may be probably because of the lower ureteric obstruction or maybe, some pressure, external pressure, because she has got endometriosis, a bad endometriosis. She had ovarian cyst also earlier. Just read it, na, fast.
Yes. Right kidney appears enlarged in size, measures 14.9 centimeter in length, Prompt excretion of contrast medium is seen in the right kidney, and the renal parenchyma shows uniform enhancement. A hypodense no enhancing lesion suggestive simple corticals is seen in the upper pole measuring 11 by 9 mm. A reductance calculus of 7.9 by 7.4 by 5.2 mm is seen in interpolar calyceal region. Perinephric fat spread up is normal. The diffusion dilatation of pelvic calyceal system, renal pelvis and upper ureter with a reductance calculus and distal ureter measuring 11.8 into 9.2 by 13.2 mm, which result in thinning of renal parenchyma. Left kidney appears normal in size and position, measures 11.5 centimeter in length, focal scarring and tiny cortical calcification seen in the intrapolar region. Prompt external contrast medium is seen in the left kidney and renal parenchyma shows uniform enhancement. A radiodens calculus measuring 10.2 into 9.0 into 7.8 mm seen in lower pole calyx. No evidence of hydronephrosis seen in left kidney. Perinephric face appears normal. Left ureter shows normal caliber and course. There is no intrinsic lesion or calculus in the ureter. Urinary bladder is normal in fetal wall thickness with no evidence of intraluminal lesions. Right renal cyst, right renal interpolar calyceal radiodense non-obstructive calculus, right distal ureter calculus causing proximal hydroureteronephrosis and resultant parenchymal theme. And focus scarring a tiny cortical calcification in the interpolar region of the left kidney and left renal lower polar calyceal radiodense non-obstructive calculus.
Fine. Rahul, next what? Now what you want to do?
Sir, I would like to counsel my patient about the condition. I would like to give her option of treatment in the form of endourological procedure.
Yeah. So what you want to do?
Sir, I would like to do semi-rigid ureteroscopy for left side with degestenting, and on right side I would like to do degestenting. And after 15 days, I would like to operate on the right side for stone.
So what you want to do for the stone?
Sir, laser lithotripsy I would like to do for the stones.
When?
No,
Second time
Sir,
on the right.
sir.
Yeah,
Left,
yeah.
left side. What you want to do left side?
Sir,
Rigid ureteroscopy.
Left side, what you want to do?
Flexible.
Mr. Rahul,
yes, sir.
left
Sir,
side, what you want to do?
Sir, left side, sir, I would like to do degestenting, and on right side, right URS.
Why you want to do digestenting on left side?
Sir, there is a hydronephrosis. I would for that I would like to place a stent.
So for each and every hydronephrosis, you place the stent. So why there is hydronephrosis?
Sir,
If you read on left side, there is interpolar calcification, focal scarring and tiny cortical calcification in interpolar region of left side. Left lower polar calyceal radiodense non-obstructive calculus. These are the two positive findings in the CT scan.
Sir, I asked you what you want to do on left side. You are saying digestenting. At least say digestenting prior to RIRS or something, no? Just digestenting, what is the meaning?
Sir,
Who is S? Please mute yourself.
sir, for left side, sir, RIRS, and on right side degestenting.
So you may not say RIRS at the state. You may say digestenting prior to RIRS. It's okay at your level. Or you may say that we will try to calibrate the ureter. If the ureter is good, then RIRS may be attempted in the first go itself. But when examiner asks you specifically what you want to do on left side, then just don't say digestant and stop there. Okay, beta?
Okay.
So my question
So,
is,
sir,
yeah, there is a the thing is there is a right-sided severely obstructed system. Patient had fever. All the medicines are resistant. All the drugs are resistant except colistin. Patient has already received antibiotic for 5 days IV. In spite of that, there is 45 to 50%. Okay. So now what you want to do? You want to do only DJ stent, or you want to do right side PCN and left side DJ stent, or you want to do only right PCN, or you want to, as I said, bilateral DJ stenting or left RIRS and right URS, because already patient is under cover of antibiotics.
And none of them has spoken about any documentation of renal function.
so right moderate to severe hydroureter with 2 stone, one in the lower pole probably and one in the ureter. And the system is definitely infected as having a local tenderness. So my asymptomatic side is also right side since long duration, 3 months. So my priority is to preserve the function of that kidney. If CT scan shows the uptake and excretion of contrast is delayed, then it is better to have a functional assessment, accurate functional assessment before doing any further intervention to avoid the medical legal issues and to know the baseline function of that kidney. That is what I feel. Another side, asymptomatic mild pain may have passed some small stone in recent past. So that may be a peristaltic wave or that may be a mild hydroureter or hydronephrosis that can be tackled with placing the stent, but that should be as a part of further plan like a RIRS. So on right side, minimum, what is the minimum? Minimum is PCN with DJ or only DJ or only PCN. Whatever you are going to tell, you have to defend that in exam. So on right side, I am not going to do any curative invasive procedure except DJ plus PCN or DJ. And on left side, prophylactic DJ stenting before RIRS if I am planning for RIRS. Otherwise, there is no any stone in the ureter, then I will give some analysis for that particular side and I will tackle that particular side whenever the right side problem got resolved. So on left side, mini PCNL RIRS. On right side, DJ oblique PCN or with PCN. And after some time, for example, 4 weeks, or settling the infection on right side, then I will go for further treatment. If you have placed the DJ, I will definitely go for RIRS because I can treat that stricture part. If there is a stricture, I can treat the ureteric stone, I can treat the lower polar. So flexible is the idea, good idea after settling the infection on right side.
So now you understood what to answer in the exam. Now,
Pankaj sir, any addition, Pankaj sir or Hiren sir, please
even
add.
Huddedar is there. Dr. Huddedar also can suggest. Because now we are going ahead with the, what we did and the complication, so that students, they know actually.
Because right side, sir, an important factor we are not discussing properly is stricture.
Stricture,
So
exactly.
that stricture is going to cause the problem whenever you are going inside or you try
Yes.
to go inside. Passing the stricture and going about to treat the stone is a not easy job.
Correct, sir. Totally agree with whatever you said. So they have to be aware that doing any intervention first is documentation. Otherwise, tomorrow patient will come and say, "Mera normal kidney tha," and you have screwed it up. Seeing the CT scan, definitely you must have a functional assessment. That is what I suggested, and you backed it up. So I think 2 examiners, even Gaurang Shah sir agrees that documentation of function is very important. Secondly, you must be aware of all these options. That it's not easy to tackle a stricture and do a stone. So PCN is also a good option. And some plan should be made also on the left side. So all that now you are on track. Now let us go ahead and see what happened.
So now I'll tell you what has happened. So because the patient had come and we decided to do both the things on the right side, this right mini pulse was not done. So we did left sided RIRS first. We removed the stone. There was some little bleeding at the end, but we put the digits and everything had settled. Right side, we did URS, and there was a definitive stricture, was little difficult to go up, removed as many pieces as possible. And because we had planned that later on we will be doing surgery for the stricture, I thought that it is better to remove the pieces by doing a mini puff. So we turned the patient, we injected dye, and we saw that there was multiple radiolucent area. Just one puncture, but it was a blood stained urine which was coming. So stopped. There did nothing, and we shifted patient to the ward. So now what happened in the night? Patient had hypotension, BP was 90 by 60, hematuria was getting, when we do wash, it was getting clear, but again there was hematuria, urine output had decreased, oxygen saturation was 88 to 90. Next day morning, when we did the hemoglobin, it was low, almost from 9.8, it had come down to 7.5 or something. Yeah, 8.2. Now, and the creatinine had increased. So, Rohan, now next what? Now what you will do?
So what do you think has happened and now how will you proceed? Sir has given you the clinical scenario. There is hypotension, drop in hemoglobin, hematuria, etc., etc., etc. So what do you think could have happened? Sir has told you both the procedures which are done.
Sir,
So how will you proceed now? Yeah.
hematuria plus acute kidney injury must have been happened, sir. So I would like to observe the patient, and
No,
I
there
would
is
like to,
hypotension also, my friend.
yes, sir. In patient is
So
already in.
will you just observe without doing anything? You're a urologist. Don't you want to do see something whether your surgery has gone off well or not? Has there anything gone wrong? How will you see? How will you assess?
Sir, I would like to do ultrasound, bedside ultrasonography.
Then simple test, no? Why don't you say it? Why do you say observation? Simple things. In some medical colleges, ultrasound is available in the ward. PGs are doing. So you must say ultrasound, no?
Yes.
At least ultrasound. People go directly for CT nowadays. So tell him what has happened, Brijesh.
Brijesh, sure. So what we did, we shifted patient to ICU, and before that we did a CT. What is this?
So Rahul, sir, if when
Yeah.
such situation occurs, there are two points. One is infection and another is bleeding. So for the cause of hypotension, you have to think why patient had a hypotension and where is that bleeding is coming from. Two
Correct.
important.
That's what I'm saying. You have to think, no? Why hypotension? You cannot say observation. You lose the patient.
So suppose if you have not done a ureteroscopy and if you have just done the digestant oblique patient on right side or with patient on right side, and if it is found that this may be due to an infection, flare up of infection, then that can be avoided. So doing a ureteroscopy in a system having an infection in situ is not a good idea. Okay, that is one thing. So already it is done. Then the patient is in front of you and patient is having a hypotension. So my first aim is where is that bleeding is coming from and why that hypertension is happening in this patient. So you have to rush and do some investigation and search the cause answer for that particular event. Okay.
So sir is right. There are two scenarios. One is sepsis, one is bleeding. But Gaurang Shah sir gave you a clear picture. What happened intraoperatively? There was some blood. There is hematuria. There is hypotension. Plus, it's a complex case, sepsis with stone, with opposite side stone. So you have to have both the blood workup as well as CT or whatever. Some imaging has to be done.
Fine. So now just read this CT. You have seen the earlier CT, correct, of the same patient. Since the case creatinine was 2.4, we have done non-contrast. Okay.
Yes, sir.
Now can you see the right side and the left side? Right side still there is a dye
Yes, sir.
because we have done RGP, and there is a air foci inside that.
Yes, sir. Sir, it is axial CT scan showing the hypodense area around the left side of the kidney.
Yeah,
With
so it's a big hematoma. See,
yes, sir, with some air foci inside it.
that is on the right side, and there is, you can see the on the right side there is a on the right side there is a air foci. On the left side there is a big perinephric hematoma.
Looks like a
Can you
right
see?
perinephric and left gross hematoma. Right perinephric and left gross hematoma.
It is intra. Right side it is intrarenal. Left side it is perinephric. Okay.
Can you see the left kidney? You can't see the left kidney only. Can you see what has happened? It's such a big hematoma. So you have to say that you are not able to appreciate the kidney. No? You saw the earlier CT scan.
Yes.
Now you see the difference in that kidney and this kidney. Earlier CT scan you have seen. So you should be very bold and say your hypodense area. You say that the entire
Yeah.
hypodense area is replaced. I cannot appreciate the kidney on the left side.
Exactly.
Okay. So patient was shifted. Patient went on ventilator. Okay. And absolutely anuria. Then we repeated ultrasonography, and ultrasonography showed that there is some free fluid now even in the pelvic region. Now what you will do?
Will you stabilize the patient or not? How you ask, sir, whether the patient is stabilized?
Yes, sir.
If the patient is
First,
stabilized, what will you do?
Now the platelet count had decreased. It had become 28,000. Okay, patient was having a bleeding tendency. INR is increased. Hemoglobin is low. Patient is on respirator, ventilator, and the hemoglobin is low. Again, it has decreased.
sir, first step is to stabilize the patient.
No, stabilize. We have given. So what are the things? What you will do now?
Sir, I would like to give platelets, sir, whole blood to infuse
Okay,
the
I'll
blood.
tell you. We have done arterial line. We have done done the central line. Okay, we have given the blood to the patient. We have arranged for FFP. We have arranged for platelets. Everything. Now, what do you want to do?
All this you must say. Huh? You must say arterial line, central line. You have to monitor the patient scientifically. If you just shift to ICU, it doesn't work. You have to central line so that you know what your intake and output is. You have to have arterial line so that you can manage if the patient crashes. You have to correct the bleeding disorder. Now what will you do? Sir is telling everything is done. Now what will you
Patient
do?
was on NORAD. We have started everything. Now, what you want to do?
Sir, I would like to repeat the ultrasonography also to
Yeah, we
see the
repeated, na?
exact,
That is on. This in 48 hours.
sir, exact collection location of the collection and sir, size of the collection and internal echoes are present.
Rahul.
Beta, it is bleeding so much. There is
12 hours.
fluid in the pelvis
12
also.
hours before. 12 hours before we have done the CT, which I have shown you. After 12 hours, we have, because patient is in ICU, Okay, you cannot just keep on shifting. So after 12 in the morning, we again did the ultrasonography and it showed this hematoma and everything, but there was a free fluid in the abdomen. Now what we will do?
You have to move, na, Rahul. There is a CT, there is a sonography done. Patient is bleeding. What will you do now?
Sir, go for exploratory laparotomy and
So what you will do? Which is the best way?
sir, best ways to do the exploratory laparotomy and look for the cause of bleeding and
Can
control the
laparoscopy also be done?
sir, diagnostic laparoscopy can be done in this patient, but if bleeding
Better, the kidney is retroperitoneal. How will exploratory laparotomy help?
That's what I was thinking.
sir,
If
there is
How much is the
Where-
platelet
where-
count, Rahul?
Where
How
has
much
the
is the
bleeding
platelet
occurred?
count?
sir,
How much is the platelet count?
Platelet was about 28. It had decreased to 28,000.
So how anyone can go for any exploration with 28,000 platelets?
sir, patient already transfused with blood and fresh frozen plasma with platelet, so that
So what is the minimum platelet count required to go for any surgical intervention?
sir above 1 lakh.
So at least 50,000. Some books it shows
50,000. 50,000.
50,000.
So that sir said
And
correction has been
in
done.
spite
Now
of
what?
in spite of going for any exploration and searching for bleeding, if you go inside, it will end up into the nephrectomy and death of the patient in this patient. So is there any way?
We can
Another
do
way.
a CT angiography. We can dialyze the patient if there is AKI, and if there is active bleeding, we can angioembolize.
Why do you want CT angiography?
Why CT angiography? Na? Sir, you said angioembolization. So for that, you don't need CT angiography. Your already creatinine is 2.8.
Now time has come and we have to act. So there is conventional angiography and block that wherever from that blood is coming from.
Unless you stop the bleeding and stabilize what further, if the hematoma gets infected, then you can go inside and clean the hematoma. But if the hematoma is not infected and you just stop the bleeding, it will help.
Yeah. So another thing is the count had become 38,000. Patient had a continuous fever 104 degree. So we kept the option open because the bilateral it was there. Okay. And the output was absolutely zero. Patient was in a a hospital where angiography was not possible. So we decided to do laparoscopy, and at least because there was a free fluid in the abdomen. So first thought was whether now there is a secondary to that bleeding, whether there is and the output was zero, whether there is a urinary leak. So we did a laparoscopy. There was a big hematoma around the kidney and going right up to the psoas, up to the pelvis. And the fluid in the pelvis was absolutely clear. So we sent it for creatinine. It was serous only. We removed almost 800 to 900 cc of blood, kept the drain, did nothing on the right side because right side it was everything intrarenal. So we just waited. We gave platelet continuously for 2 to 3 days. Then next day about 1400 cc of blood had come. Hemoglobin had dropped to 5. But with the blood and plasma and platelets, ultimately everything settled down. But still urine output was zero. Now what we will do? And the continuous fever, and patient count is continuously high. Yes, Paras.
We will find spores for infection. This patient is having on multiple lines, central line. There can be associated pneumonia, atelectasis of lung. We can search for any collection inside the abdomen.
No, the two drains are already there. One in the pelvis, one perinephry. and otherwise there was nothing. So in
For
this
fever,
case, in this Pankaj, in this case, if all the facilities are available, we should have done bilateral angiography.
Yes,
Sir,
this patient needed angiography, to be very frank. And
Good.
I would really not have done laparoscopy in him because laparoscopy would not have changed anything.
Hmm.
Okay.
No, because
two,
there was a
three,
free fluid in the abdomen, and that abdominal distension
No,
was
so
there.
still free fluid means, you see, even if you see urine or if you see blood, what is the next step you can do on laparoscopy? Practically nothing.
two, 3 points I want to just tell for the residents. Don't tell ureteroscopy when the system is infected. Number one. Number two, if the patient has a bleeding, don't do any exploration until and otherwise your minimal invasive options is exhausted. Okay, these are the two crux of the points. Keep in mind while giving answer in the exam. Practically, a number of things can be done with the help with our experience and requirement, local requirement. Okay, 28 lakh, 28 lakh platelet, 28,000 platelet count. So nobody will touch that patient. Perinephric hematoma with exploration, which is outside the peritoneum or in the retroperitoneum. So that should be retroperitoneoscopy. So if you ask, told in exam it is a laparoscopy, then for fluid, then the person like me will ask, why you have not done just a fluid creatinine? Is it a urine or not? Okay. So as far as exam is concerned, in this particular patient, your answer is N at PCN oblique DJ on right side and DJ can be defended on left side. What you will do and when? After 4 weeks, I will reassess. With due consent, I will go inside on right RI areas. If scope goes across the stricture. If not, then the stricture and stone can be tackled by open, laparoscopic, robotic, anyway by uretroplasty, ureteric anastomosis, or Boary flap as per the height and length of the stricture. And proximal stone can be tackled in same setting. Or by the same way like RIRS or by different way like a mini PCL. So this is on right side, left side definitely RIRS. So this is how the exam is over. Now what sir has done, it is out of the experience. ये सब चीजें करने के लिए बहुत सारा टाइम जाने देना है, आपके लिए नहीं है वो चीज.
No, that is why this case has been selected so that they know what is to be rightly said in exam. This is the most important thing. So after that, again patient improved. 10 days, patient started passing urine. 1400 cc. We had done completely dialysis, platelet improved, WBC count had also reduced, and patient started passing urine 1400 cc per day. One fine day, suddenly, Monday morning, output was zero. Absolutely zero. Now what you will do? And sonography showed that there is a collection in the left side and there is a right kidney, again, severely hydronephrotic, and there is, clots inside it. So now what you will do? So when the output was zero, the count had increased, platelet had not decreased, okay, abdominal guts had increased, BP was high, patient had fever, drain hardly anything, and actually in fact we have removed the drain. because almost 10 days were over. So now what you'll do? Paras,
Hello.
yes, Paras. So anyway, I will tell you. So we decided to again shift to the patient to the other institute, and there we did a CT angio. By show the CT angio. Show them CT angio properly. Yeah. Rahul, can you comment something?
Sir, pseudoaneurysm on the right side of the kidney.
Yeah. And can you see the kidney has become very large and
Yes, sir.
and the digestant is in on both the sides.
Okay.
And there is some collection on the left hand side just below that.
Yes.
Okay.
Yes, sir.
Now what you will do?
Sir,
Since patient had fever, continuous fever, and there is a collection on the left side, we thought that why not to do ultrasonography guided? Put a pigtail. Okay, so we put a pigtail on the left side. And because patient continuously had a fever, we thought that now there is a fluid, hemorrhagic fluid in the right kidney. We'll again put a pigtail in the kidney and drain it out so that infected urine or infected clot, we can drain it. Paras, tell them what happened.
So we put a perinephric drain on the left side. There was that 600 serosanguinous fluid which came. Ultrasound guided right nephrostomy was done. We aspirated it. There was 10 ml clot. Then there was a rapid spurt of blood from the right percutaneous nephrostomy. We just closed the nephrostomy, and the patient was shifted to the ICU, and we observed the patient for 2 days. There was no active perinephric collection or increase in the size. After 2 days, the patient started having abdominal distension. There was a right flank fullness. There was tenderness. The right upper abdomen was firm to hard on palpation, and patient's hemoglobin dropped around 4 gram per deciliter. So patient was taken up for right exploration. We did our right-sided nephrectomy.
Just show them the specimen. So ultimately, what went wrong? Just show them the specimen. So Rahul, coming back to the first thing, how will you tackle this patient? If this patient has got a right ureteric calculus, infected system on the right side, left-sided calloid cell stone.
for left side, I will do the PCN, and for
Left
the
side?
sir, sorry, just putting on the left side for the future or RIRS. If user is allowing the scope, and on the right side, and
Your connection is not good.
hello, sir. Hello,
Yeah.
sir.
Yeah.
Wow, that is one video you should.
Hello, sir. Hello. Hello, sir.
Yeah, we can hear you.
Okay. Sir, on left side, I would like to do degestenting. If ureteric caliber is good, then directly I would like to go for RIRS. On right side, I would like to do PCN. Degestenting only, sir. And after stabilization, the patient after 15 days, I would go for definitive management of stone on the right side.
And suppose if you are not able to put, because it is an impacted stone. If you are
I am not able to pass the glide wire or glide wire, then I would like to go for the right PCN, sir.
okay, Gite sir, now your final comment, yours and Maheshwari's final comment.
Rahul, patient had a right-sided ureteric stricture. Proximal to the stricture, there is a stone. Patient had a right-sided infected system. So I will take a consent of digestant with patient before going or before entering inside this OT. Because then considering the stricture, two obstacles. One you have to overcome is the stricture, another you have to overcome is stone. Usually proximal stones above the strictures may not be fixed until and otherwise it is long standing. So chances of having a digestenting here is 50-50. So your second plan B should be always on in terms of PCN. So with PCN or without PCN. Digestant with PCN consent लेके ही अंदर जाना है. Where that place your treatment on right side is over. On left side, if patient is more symptomatic, for example, then left mini PCNL versus left RIRS. The matter on that side is already resolved with this either of the treatment options. Prior digestenting can be defended, may be required, may not be required on left side. On right side again, if you are able to place only the PCN, then mini PCNL with that same track and open oblique laparoscopic oblique robotic surgery for stricture and stone on right side. This is what the plan should be from my side. If any changes or additions from seniors can be added. Pankaj
No,
sir, bolo.
only one question I want to ask, that now third time when we did angiography, we came to know there is a pseudoaneurysm. Then that also venous pseudoaneurysm, and that cannot be there. You know, it has to be post-operatively. That is what the radiologists are telling me. So my question is, right-sided, we have done only URS, and so much of bleeding has taken place. Can we avoid bleeding on the right side by doing PCN or by doing any other thing? Maheshwari ji, what is your take home?
Sir, I will first go to the first question that was discussed as to what we learn from this case.
Yeah.
So my major learning from this case, which I really compliment you for presenting this case, because most of the people will not want to show such complications. The major learning here is that, you see, in endourology, there is always an opportunity to come again next time. So if there is slightest doubt of infection, stage and come back. Now, how you stage? Digestant is more comfortable for the patient, though both digestant and PCN would reign equally well as far as infection is concerned. So if your stent goes stent, otherwise put in a nephrostomy, come again another day. Okay. Now, recently we have started doing a study where we look at, say, CRP, we look at albumin globulin ratio, and we obviously look at the other infection parameters. Even a CRP more than 10 should be a sign which, say, you should start looking at that case more seriously. This patient had a CRP of 50 or 40, I don't remember exactly. So whenever you have a doubt of infection, just place a stent, do no upper tract procedure in presence of infection. So that is my point number one. Point number two, sir, this pseudoaneurysm cannot happen because of ureteroscopy. Has it happened because of the nephrostomy tube that was placed later on? Means that is either the
No,
nephrostomy tube.
this
or the type-
angiography is before nephrostomy.
Oh, angiography is before nephrostomy. Okay,
But
because
sir, they
with
had tried to puncture the right
then it's
PCS system.
practically impossible to explain.
Sir,
And
they had
again,
tried to puncture the right
that you
PCS.
see
No, no,
is
no,
very
no, sir.
Sir,
Yes.
they had tried to puncture the right PCS after
They
the right
have, they
URS.
have done a puncture on right side, but may not have
After the right
dilated. That
URS.
puncture needle may have gone through the vein.
Correct, sir.
Yes.
Correct.
Yes. So some upper tract percutaneous intervention only that can. And you see the two pseudoaneurysms that you see, one is very peripheral. It is nearly something like subcapsular. So that is definitely. And if you again see, yes, that one. And if you again see, that is very medial. So which just shows that this probably was a poorly aligned puncture for the upper calyx. You would usually not puncture at this place. So overall, sir, the lesson for the student should be that in infection, stage and come out. First opportunity, put a digital stent. Do not take flexible ureteroscopy lightly or even a rigid ureteroscopy lightly because the volume of the pelvic calyceal system is very small. Slightest rise in pressure can lead to dissemination of infection. So stent, put a nephrostomy, come out. You can always fight another day.
So in addition to whatever Pankaj sir said, I have to make one comment that whatever sir said is very important. Do not take it lightly when there is infection. My additional comment is that this case, left kidney was very, very important because the patient is going to survive on this left kidney. So that flexible ureteroscopy should be done with extreme caution, or even if that mini perc is done, it should be done with extreme caution to prevent as much as complication as possible. This is the kidney on which the patient is going to live. And luckily, the patient has got the left kidney and the right kidney has landed up in nephrectomy. So that is one extreme caution that should be taken. In such a case, even if you stent and stage and do RIRS after 1 week, there is no harm because you'll have a better ureter, better system, and easy entry, and you'll safeguard the ureter as well as the pelvic calyceal system. And pressure in any upper tract surgery is condemned.
Okay, fine. So I hope that many points are, resolved and many queries has been solved. So in exam, when such a case or any case comes, you know how to answer. So Rahul, you or anyone else has got any questions? We have got actually other two cases, but we are not
Sir,
taking it. Next time
sir,
we'll do it. Similar
few
cases, but we'll do next time.
few questions they have asked in the chat box.
Yeah.
So I will read and we should have reply. Should reply that.
Yeah.
Patient come with urine culture positive which resistant to all antibiotic. How to further proceed?
My answer will be best thing is to give reference to the uh, this thing, infectious disease doctor, because even though it is resistant, they know the right drug to be given in the right dose. And so many times I have seen that because of that we are able to cure the infection. So best thing is in such cases you consult infectious disease doctor.
Majority times, infectious disease specialist may not be available in a places where people are working. So
No, you can
what
telephone
we
them,
used to
man.
do
No,
or I do is
no. Nowadays, what we do the telephone consultation. They see it is not necessary for them to come to your place only.
no, that's
So
what
what we do is we send all the reports and then he advises.
agreed. That point is totally agreed. But routinely, as a routine practice, the you just check the sensitivity report. Okay.
Hmm.
And the drug which has not for which they have not done a sensitivity testing, and the drugs which are not routinely used in a urological practice, like nitrofranton. Recently, we are using in very large number. Then phosphomycin. Recently, we are using not commonly used drug. So such for doxycycline. Some drug you have to start, which is
Astronam.
urinary antibiotic, and do a culture on antibiotic. That's what policy we are using in such type of patients. And in second culture, definitely there will be some sensitivity to some drug. That's what we are following since last many years, and that is working. Maybe
So,
scientifically true, may not be true. I don't know exactly, but seniors are always there to guide
yeah.
in such
And
situation.
one more thing I would like to tell about this patient is that now at the end, urine culture as well as the blood culture has shown fungal infection.
सर वो तो पेशेंट का खतरनाक कार्यक्रम हो गया है सब आप कैसे क्या हैंडल किए
No, I want all of you to pray for her. Still, she is fighting, and of course, little improvement is there, but she is fighting. Okay, so second question is if DTPA shows less. See, in this case, we have not done DTPA scan because CT IVP was showing a comparatively, even though hydronephrotic kidney, you can see that the whole kidney was opacified, even the ureter. So, considering this, it is definitely more than 15%. You know, of course, you cannot judge on that, but that is a functioning kidney. So that is why we have
no
not
agree
done DTPA
sir
scan.
it is better to go ahead with a DTP scan in a patient having a right sided moderate to severe hydronephrosis stricture stone all the things are there so it is better to have a
Yeah,
DTPA for baseline function one and another thing is क्या है कि आप हमने कुछ भी किया वो किडनी अगर समझो नेफ्रेक्टोमी हो गई तो
yeah,
पहले का फंक्शन हमारी वजह से या फिर खराब हो गया ऐसा बोलने के लिए वो सपोर्ट हो जाता है सो
right.
ऑलरेडी
I
वो
agree.
किडनी खराब फंक्शनिंग कर रही थी काम नहीं कर रही थी ऐसा बोलने के लिए एक मेरे पास पॉइंट रहता था अगर मैं प्रायर DTP स्कैन करता था दैट्स व्हाट आई ऑलरेडी टोल्ड so it is better in such situation go ahead with DTP scan if
So,
any
Also a patient, sorry, and also a patient who has been previously operated multiple times, it is better to have a baseline DTPA rhinograph.
so another one more extra point we have learned is that whenever you find that there is a compromised function, a hydronephrotic thin wall, even though on CT IVP, because it is reconstructed image and it may appear that it is a good functioning kidney, always do DTPA scan and tell this in exam. That is the most important thing, right?
Yes.
another questions they have written is patient came with lower calcareous stone with hydronephrosis then why there is hydronephrosis
Yeah, that is probably because of I told patient has undergone she had a large ovarian cyst. She has undergone surgery for the same laparoscopy and she has got endometriosis. So probably that might have caused some pressure effect on the ureter and that is the cause of hydroureter hydronephrosis or the fullness.
So you can also in exam give urological reasons like intermittent obstruction of stone and maybe a small stone which has passed off.
Yeah.
exactly
Okay.
another questions they have asked is why CT already why not NC CT so probably enough is discussed another is X-ray sir how to measure the size of calculus in X-ray QV and CT film and IVP film
Okay, so you see, mm, in the digital images, you will not be able to measure the size accurately. It is the radiologist who needs to measure because we do not know what is the say means change in the size of the image they have done. Okay, one rough guide will be that the height of lumbar vertebra is around 3.5 centimeters. So you can compare it to that height and then take a approximation. Okay. So lumbar vertebra helps us in two ways. One, the approximate HU of lumbar vertebra can be taken as 1000. So if the stone is denser than lumbar vertebra, then probably it's a hard stone. And based on the height of lumbar vertebra, you can decide what is the size of stone. Similar will apply for IVP. The best way to diagnose a size on is by CT scan. Again, in CT scan, it should be a properly reconstructed image. You see, the ureter is not a straight tube. At some places, it curves. So if you just see the make the oval, then probably that will be a underestimate of size, because that curve of the ureter has not been taken into consideration. So they need to really rotate the image in a way that you get the proper long axis of the stone and then measure. A lot of discussion is happening whether the size is really important. You see, you say it's a 10 mm stone, but the stone is a three-dimensional structure. We want it 10 by, say, 10 by 8 by 8 will be much different than 10 by 8 by 3. The volume of the stone is more important. So these days there are a lot of volumetric parameters, volumetric measuring systems which have come on CT scan, which will give you the exact volume of the stone. One important thing is how to measure the size of the stone on sonography. You see, CT scan is usually easier. Sonography always underestimates or overestimates the size of stone. The better way to look at the size is to look at the size of the post-calculus acoustic shadow. That is a much better indicator of the stone size than the what you exactly measure on the sonography. So overall, one dimension doesn't help us. We need three dimension. We do not need the area of the stone or the length of the stone. We need the volume of the stone. And there are a lot of CT, say, programs or apps which are able to give you the exact volume of the stone, because that is how you will decide whether you are going to do a RIRS or a mini PCNL. So as I told you, 10 by 8 by 2 millimeter will be much easier for RIRS than a 10 by 10 by 10 millimeter. Though on single imaging, both will be 10 millimeters.
So 2 points
So I
wanted to
think
add to your
anything.
2 points I want to add, sir. Whatever you said is right now a lot of papers are coming up on the volume because sometimes, like sir said, that you may think it's a 2 centimeter stone, but actually the volume is equal to 4 centimeter. So you'll be in for a big surprise. So volume is the most important thing in today's day and time. And second, while judging the density, it is good to tell your radiologist to look at the bone window rather than seeing the abdominal window. So that gives a good accurate density measurement of the stone.
Fine. Okay. The only
And
thing I want to
it
tell,
is important that we ourselves should try to see the CT images rather than relying on the radiologist. More often, you see, they do not give that much significance to Hounsfield unit. Like in this patient on left side, it was written 2200 as HU. Now 2200 is practically impossible. I have never seen a HU
Correct.
more than 600.
Agree,
Okay.
agree. Yeah.
Maximum, I remember one patient having 1750, but usually 2200 is a nearly impossible HU. So what happens is that they do not draw the ROI for HU properly. Again, you have to go in bone window. You have to enlarge the image as much as possible and measure it at least 2 to 3 places and take a mean of that. Because many times the HU of the stone may be different at different places of the stone. The periphery could be much harder than the center. So all this information is important for you when planning the RRS. So it is a good idea that you should go on the console, see the CT scan, measure the HU yourself, measure the stone size and volume yourself, and then take a decision.
So plus multiple discussions with the radiologist, they start incorporating these things. Like it's
Yes, you
SEFI,
need
they
to
have
train
now.
them into exactly what you
Yes, sir.
want.
At SEFI now, they are doing these things for us. They are doing the volume, they are doing the bone density. Even when they are renal tumors, they are giving us a renal score also. So they have become very interactive because we interact with the department. Probably this city was done somewhere outside, so we don't have that exact definition of the HU.
See, going back to this today's case, one more thing which was striking, which we did not discuss, was if you look at the stone of that ureter, there was a big radiolucency in that stone. So it was a periphery was dark and center was radiolucent. Now, whenever you have such a stone, suspect infection. So that was one more sign of infection that we could have. These are all in retrospect, you think. Prospectively, you may miss these things. But if we are aware, we observe these things better. So whenever there is a radiolucency, either it's a stone which has formed on papillary necrosis, or it's a sign of a long-term infection.
Yeah.
I agree,
Yeah,
sir.
everything was considered. I agree. And because patient has already received antibiotic, IV antibiotic for 5 days by a physician and all these things, But lesson is learned, and the most important thing is students should know what to answer in exam. Actually, when we
Absolutely.
opened, this kidney had already ruptured, and there was a blood going right up to the subhepatic space and even subdiaphragmatic, everywhere it was there. So, it
Sir,
was
it
like,
is your long
so
experience that you could do this open surgery. A lot of people in today's time will not be able to do this open surgery. It is not an easy open surgery.
Women was frightening
तो
seeing
आप
that
कर पाए,
specimen.
हमें करने की जरूरत पड़ी तो आपको बुलाना पड़ेगा.
anyway. So next time we have got another 2 cases similar, okay, but not such a so many complication, but the same principle that what you should answer in the exam. Okay. So hopefully you will be back and fresh. Okay. Pankaj, thank you very much for participating from USA. Thank you very much. Gite sir, Hiren, thank
Yes,
you
Thank you,
very
sir.
much.
sir.
Yes, sir.
Thank you, Pankaj sir.
Thank you,
Thank you,
sir.
Gite sir.
Students are
Thank you,
so
Gaurang sir.
blessed because of your presence.
Arre, sir,
Thank
thank
you,
you so
sir.
much. You see, I feel good to be part of this endeavor, because being a treasurer, I have been traveling so much all over India, and at so many places, people really swear by these classes. Means there are so many people who come and tell me that, sir, we have learned from you. Though all credit goes to you, not to me or Dr. Gite or
Maybe.
anybody else.
Agree,
It is
agree, sir.
your
It goes
perseverance
to
that
you
this
people
is going
because
on.
when you are talking, I keep silent.
No, no, sir.
In fact,
It
in
is a
fact, sir,
teamwork,
because of
and we are
Gaurang Shah sir's
persistently doing since
motivation, we
last
all are
4 years.
able to sit for 2 hours. Because of your
Absolutely.
motivation, sir, we are able to sit for 2 hours. And actually, as Pankaj sir said, every time students are thanking us, and it's all because of you. And it's good that we are very happy that the students are learning.
Yes,
So it was good to see 65 participants. It's very encouraging for us also as teachers.
Yes.
absolutely.
Fine.
Have a
Yes.
good trip, sir. Pankaj sir. Good night.
Thank you.
Good night,
Thank you.
Gite sir
I'll be
and
back
Gaurang
in
sir.
India on 8th. So definitely on Wednesday, I'll join, sir.
Yes, sir.
Okay.
Yes.
Sir, next
Yes.
time is on Tuesday, huh? Next time is
Tuesday.
on
Now
Tuesday.
again Tuesday.
Tuesday.
Okay, Tuesday. So, sir, I will be in flight.
You will be in transit.
I will be in flight.
Okay,
Okay,
sir.
sir. Okay.
Okay, sir.
Okay,
Good night.
Thank you,
Bye,
sir.
sir.
Good night.
Okay. Thank you, sir. Thank you, sir.
Bye, bye. Well
Sir.
presented, Rohit. Keep
Sir.
proactively presenting, okay? All of you.
Yes, sir.
Yeah.
Yes.
Good.
Thank you. Good night, sir.
Yeah,
Good night.
Gaurang sir,
Well done, Paras,
kindly end
Brijesh.
the
Thank
session.
you.
Huh?
Paras and Brijesh, thank you. Bye, bye.
Thank you,
Sir,
Paras. Okay?
session end किए थे गौरव सर.
मेरे को खाली end आता है, मैं क्या करूं?
हाँ, end the session कहिए तो.
End the session नहीं आता है, खाली end आता है.
हाँ, बस वही करना सर.
End meeting for all, correct?
Yes.